this HER2 low and ultra low.
Yeah.
How is it gonna be? How is it gonna plan out? I can tell you from an academic perspective, we've been meeting so much with our pathology colleague to try to find a way. What are we gonna do with this ultra low? Are we gonna retest all our samples?
Right.
What testing we're gonna use? Because on the study, they used a specific antibody to check for HER2, which clinically there's many different antibodies.
Right.
Should we check that only one because that's one the study? We should check different one. Should we even bother labeling ultra or just give it to everybody and look who responds and who doesn't respond, and then change therapy on those who doesn't respond? How do you think from a community oncologist practice, how do you think it's gonna pan out, especially this ultra low?
Especially the ultra low. I think it's going to be driven by some practical decisions. I think the idea of using a super highly specialized antibody is not something that a lot of community hospitals or even large hospital networks that serve community settings are necessarily going to adopt, unless that's something that comes out of the ASCO-CAP guidelines. I hear that they're revising the ASCO-CAP guidelines. So when I asked my pathologist and tumor board the other week, hey, when am I going to get a HER2 ultra low reading on 0+? And she said, when ASCO-CAP comes out.
Okay.
And so I don't think it's going to be too terribly long, but I do think that that's probably where in the community we're going to see most of our HER2 ultra low guidance coming from. As it stands now, if I want it, I just call and ask.
Yeah.
And I'll get it within a couple of few days, and I'll get it faster than I'm going to get a PD-L1 back probably. So it's not that difficult to get, but it is that one extra step. And when you're in the community and volume is part of your practice, you don't have protected time necessarily, those extra steps really add up.